There's a lot of stuff. Okay. Morning, everybody. There's an excited crowd. It's the last day of August. September's here. Today Lynn put together a presentation for us. She was kind of voluntold, but she did a great job. Just special considerations for our special needs patients and pre-op and PACU. So just to bring awareness, we're hopeful that spark some dialogue and we can move forward best practice for these patients. Everybody on Zoom, just make sure that you are on mute, and if you can't see anything move forward, let me know, but I think we're up and ready to roll. Your notes should populate there.
And then I just hit next.
And down here.
This is my special population, Walter. He is free if anyone wants him. All right, so dental patients in general anesthesia, typically we're doing them under general anesthesia because they're unable to tolerate an exam or treatment. Most likely they're going to get their teeth extracted, mostly because when they restore them, the failure of that is 32%. So that's typically why they're going to do extractions over restorations. Patients with autism don't have a higher anesthetic risk other than others, but more teeth may be extracted due to cooperation issues and poor oral hygiene. And then additional anesthesia conditions are needed for patients with Down syndrome and cerebral palsy. With Down syndrome, there's some facial anatomy that can affect the anesthesia, and also with the cerebral palsy as well. I was on the wrong page, that's why. Patients with Down syndrome, because of the anatomical differences, they do have a higher incidence of upper airway obstruction. Let's see, and then a lot of them do have some cardiac conditions as well. So pre-op consideration, the pre-op phone callers tell the patients to arrive about an hour beforehand versus our typical 2 hours, just so our patients aren't here just sitting and waiting, getting bored and worked up. And then they do communicate any special needs on our charge nurse sheet. Typically, I page anesthesia and I go straight to the anesthesiologist. They do a pre-op review the day before, so they know they're coming. I page them right away so we can come up with a plan on how to best get this patient ready for surgery. I will tell the patients and the caregivers to do whatever they can, whatever they will allow. Some patients won't let you take off any clothes, and typically anesthesia and dental, they're okay with it, because if it's going to be more of a battle, if it's going to get them more worked up, it's not worth it for their stress level, and in turn the caregiver parents' stress levels as well. Definitely involve the caregivers and parents. They know these patients best. I like to ask the parents right away, what are they going to let me do? Are they going to let me do vitals? Am I going to be able to do an IV? Sometimes just giving them space and letting the parent close the curtain, giving them space so the parents can get them all ready to go. That works well. And other times they won't let you do anything, and you just have to talk to anesthesia about giving some medication. There was a study done for oral versus IM versus SED that the orals actually preferred. They work pretty much the same, and neither one of them really extend recovery time or anything. But then again, it's talking to the parents. How are they going to take this medication? Do they want it in a cup? Do they want it in a syringe? Is it easier if I give it? Is it easier if you give it? But really talking to parents and being on the same page for that. And then these are from our educations for the special needs patients. In extreme cases, they will do a ketamine dart, and oral or IM ketamine is administered by anesthesia. And after we do that, as soon as the patient's kind of drifted off, we do want to put them on a monitor so we can watch them. And then after that, we can do our IV and everything. And then this was also from education about intranasal versed. I'm not really seeing a lot of intranasal versed used. Does anybody else? Yeah, and pediatrics at MAT, but will they do it for adults at MAT? Do they? Okay. But here's just how that is given. I haven't given it over here personally though.
They do have those. Side,
Hmm.
so if
The
anybody's
atomizers.
go over.
You can give it to them. Yeah. Intra-op considerations, usually the most challenging aspect of like pre-op and getting them to surgery is getting the IV. So working really closely with anesthesia. Usually I've had it, well, they'll jump in and help us get that IV in, and whether it's a couple people holding or making sure they're totally sedated. But once you get that IV access, I think they're usually pretty much good to go from anesthesia. Patients with autism have a lower sensitivity to anesthesia, leading to higher dose of propofol and delayed recovery time. The propofol dose required for patients who use anti-epileptic drugs is more than that in patients not taking the medications. And other considerations are patients receiving MAOs or selective serotonin reuptake inhibitors also have a higher risk of hypertension and coma after general anesthesia. So these are just things that anesthesia should be considering when we're taking care of these patients and what medications they're on. And then in post-op, emergence can be longer in patients with intellectual disability compared to those without. And then there are greater difficulties in maintaining airway due to some of these medical conditions. So really watching these patients, making sure they're safe to go home and okay to go home. And then also involving caregivers after surgeries too, because sometimes they have a really long drive home. They would prefer them to be a little bit sleepy, but as long as they're maintaining their airway and you talk to our anesthesia and PACU, usually they're okay with letting them go. But definitely in some of our patients, we want to make sure that they are going to be able to maintain their own airway prior to them going home. And then the prolonged emergence time from anesthesia is correlated with cholinergic dysfunction in patients with mental disabilities, which is why it's a little bit longer recovery time. Other times they just pop up and they're ready to go, which is fantastic. So the risk of complications is dependent on the patient's ASA classification, just like every other patient, medical conditions, type of anesthesia, and type of surgical procedures. Airway obstruction is the most common complication, followed by nausea, vomiting, and airway obstruction is usually for those patients with the anatomical differences and difficult airways. But despite all of these complications, general anesthesia can still be performed safely and routinely. And I mean, we do it every day without a lot of complications. So, but how can we support these patients better in our PACU? I think we all do a really good job, and I think we all enjoy taking care of these patients, especially when they have good outcomes. But involving the caregivers and parents in both pre-op and post-op, having a plan with anesthesia, like teamwork makes the dream work, and then closely monitor in PACU. Does anyone have anything else that we could do more so? Yeah, so sometimes putting a patient in the ISO room is best for that patient if they need to decrease or they get really like overstimulated. And then I always try to give an extra nurse to be on hand too if we do that. So just for safety. So Mott had a project that they implemented a comfort plan because they obviously work with autistic children every single day. So they have a comfort plan that they do, and essentially these questions are asked ahead of time, and they have a comfort plan in their chart on the sticky note. But these are a lot of questions that we're asking like rapid fire when the patient comes in to assess the patient, so we know how is best to work with this patient. But things like how do they take medicines, like how's the best way to communicate, how will I know if they're in pain, what makes them more comfortable, what makes them more anxious. So yeah, this is something that I think in the future we could like as a unit work on to get all of this information so it is for all of us to see that's taking care of the patient. Because sometimes I'll try to like if I have a patient pre-op and something worked really well to comfort this patient. I'll go to try to find that nurse and packing, like, hey, I noticed this with this patient. But so I think having something like this in the chart would be helpful. Anyone? Like ahead of time?
Ahead of time, to have to fill it out.
Yeah.
Before they even arrive at pre-op.
Yeah, I think. Mhm.
Yeah, so then if they don't fill it out, then we need to do it after a call.
Right.
Yeah. Don't want to pre-op callers.
Mhm. Mhm. Yeah. Definitely things to think about. Any questions, comments, and concerns? This is Walter at the beach.
How did you get him?
It's a daycare,
Oh.
doggy daycare. They get
They
it.
had treats.
They obviously get treats and or balls.
Beach.
Oh yeah, that's my dog. That's Walter. I can't stress this enough, he is free.
Walter. Team Walter, you have fans for Team Walter.
Oh.
You know what, they can spend a day with him.
You did a great job. Thank you. I
Yeah.
think, it was perfect. I think obviously this intent was like to get some dialect going and hopefully, you know, if we take something like what Mott has done and we can have a sheet of paper or something in special needs, you know, that we can, get a process in place and
Like a
utilize.
standardized set of questions, so we can all feel
Yeah.
confident going into taking care of these patients. 'Cause I feel like a lot of times, especially with parents, if they're stressed about the situation, us kind of fumbling in and being unsure, I don't think that's gonna help their stress
Yeah,
levels.
they want to know that we're confident in our
Yeah,
ability
that we
to
have a-
take care of their,
Plan, and we've done this before, and.
yeah.
This is a good project, poster project, because Mott has a poster.
They did
on
do a
it.
poster on this.
Yeah,
Yeah.
so Lynn needs some help.
So what a poster consists of is essentially you've already done a lot of the legwork. Now it's putting this presentation on a board, literally, and then having a little bit more rationale and then like coming up with a plan. You know, if we do implement some kind of interview process or, you know, questionnaire or whatever, and then we can trial it for, you know, a couple months and then see our outcomes, see if it did work or it didn't. And that's essentially what a poster presentation would include, just to take this a little bit further. So, what else, anybody else have any other suggestions? Like I said, this is to open up some dialect. Megan, can you elaborate on or anybody else on Zoom? Like, what all do you guys ask when it is a special needs patient?
Lastly, how do they do in medical situations? We ask if they station for medical procedures or vitals and stuff like that, but we don't ask like how meds are taken, how they express pain.
Yeah. You can safely do it, decreasing the volume, heart monitor beeps are huge. That's a good point.
Like that. Is that wild? You won't even go into reception A, so the employee just decided from here. But no one knew, we're like, how did we miss it? You know, so it's like, that's part of the. Yeah.
So I think that, yeah, if we're able to do some kind of a little bit more elaborate screening, get information that we'll be able to have a plan in place so we can avoid, you know, a really traumatic experience for anybody. I think that'll be huge.
I think this is an opportunity for us to enhance for the special needs, just like Mott did, they
Which I
put
think-
a process in place.
Right,
And
like we do a good job already. Go to the dental clinic.
Yeah, a lot of our specialties are.
Even if there was like an email script sent out, like when they book the surgery, it's in their portal, and then we can view it as they are, arriving pre-op.
Mhm, mhm.
Yeah. All good suggestions.
Yeah. Then there's one about decreasing volume on the heart monitor,
Yeah, just
especially in
to
vacuum, make them more comfortable.
decrease the
Mhm.
stimulation, like that's a lot of times overwhelming for them, pre-op and PACU.
Mhm. Mhm.
Anything else? Well, hopefully this gets the ball rolling and, if anybody's interested in tag teaming, I would say, with Lynn, and we obviously will help you guys. I think that this is an important topic that we can really dig a little bit deeper. We get Kristen involved as far as, making sure everything's by policy or whatnot, and then kind of go from there.
So I think working with anesthesia too, because I know
Yeah.
sometimes when they come in, the nurse doesn't necessarily know like who to page or they don't respond right away. So I think having like a more
Standardized.
plan with anesthesia too.
Yeah.
would be helpful.
Feed out like Mont does, if we got that out early to the family, I think that would help anesthesia as well. Make a plan, and maybe you have a plan earlier
Yeah.
and already have the orders. In a perfect world.
Yeah, definitely.
Maybe we couldn't take it with that.
All right. This is our next poster.
I have a question.
She wants to go to that.
On topic, so it's not about fairly screen and stuff, but with that population, I'm just curious with the pregnancy test. How do we get, like, if a parent refuses pregnancy test?
If it's a parent or guardian and they
Just
refuse
find
it,
it.
they can find it.
Is it on the, like, it's on the
Yeah.
consent form?
Yeah. There's like a check.
Like the search book. They.
The question was for everybody on Zoom, how do we make sure that they can, if a patient's family member is refusing a pregnancy test, that is on the consent form, a specific box underneath the signature or underneath the pregnancy testing section that says refuse, and they have to have the discussion with the provider, understanding we're going to proceed with this, even though you're saying you're refusing to do the pregnancy test, that's acknowledged on the consent form. So that's a good question, because we do, these are of age. We do a pregnancy test on everybody 11 to 55. So you just don't know. Yeah.
Sometimes I feel guilty, like these are the people that we really.
You do really need to screen.
But
Yeah.
they can't see or they won't, and it's just, sometimes I'm like,
Yeah.
this is.
You
Yeah.
could always try to do
Try to
a blood
advocate.
test though, when you.
Like if you do have like a lot of.
They'll take an hour to
It's
come
take
back.
at least an hour, and they're only here an hour. The blood, yeah, it takes forever.
If
Well,
there's an
it's one
absolute
way to, like,
concern, like if it's
yeah.
truly like, for whatever red flag is telling you that you need to make sure they have a test, discuss it with the anesthesia. And if they truly want it done, we can wait, we can wait for that blood test to make sure that it's accurate. But. Good question. Steph Virtue said, I always worry about abuse in this patient population. They're not able to speak for themselves. Might have to count on the caregiver who might be an abuser. That's 100%.
That's when you should be looking at the indicators.
Yeah, looking physical, indicators, if you see anything, any kind of red flag, that we can always get social work involved, even if you have a hunch. Because if they're nonverbal, if they're, not able to speak up for themselves, they perhaps could be essentially a number one target. Yeah.
Down syndrome versus like autism. There's such a spectrum. With Down syndrome, you can be, you can
You can be
physically-
high
you have the physical
functioning.
characteristics of
Yeah.
Down syndrome, but they can do everything.
Absolutely,
Right?
yeah,
You know, and it's so hard,
yeah.
so hard.
That's definitely a challenge of our job, you know, that's why we're really trying to advocate for the patient and, you know, that's why these screening tools are in place. And if you can communicate however, can like with the patient and caregivers, just do your best. Anything else? Any other questions? Thanks again, Lynn. Good job. We'll keep the ball rolling on this topic. Thanks, everybody, for chiming in on Zoom. Have a good day. Thanks.